Good morning, good afternoon, good evening, everyone. Welcome to the CCIH 2022 virtual conference. My name is Mona Bormet, and I'm the program director at CCIH, and I'm so glad you could join us for the conference today. So on the screen right now, you should see a slide that has instructions for how to listen to the conference in English, French, or Spanish. So there should be a button at the bottom of your screen that says interpretation. And if you click on that, you can choose one of the three languages. So hopefully you will all find that at the bottom of the screen. If you are new to CCIH, we are a global network of approximately 120 Christian organizations and 15 secular partners, as well as a few hundred individual members. And our mission is to promote health and wholeness from a Christian perspective. We provide opportunities for capacity building, networking, sharing best practices, and advocacy. So just a few housekeeping pieces, some logistics for today. We will hold all questions until the end of the program today, before we go into breakout rooms. So at approximately 10:15 Eastern time, we'll start Q&A, and all the questions will be collected until then. So please use the chat box to introduce yourself and to also ask any questions. We have staff who are monitoring that. So today's session is being recorded and will be posted on the CCIH YouTube channel, on our conference playlist, and you'll also find links to the recording for today on the CCIH website, so ccih.org/events. And we hope you join us today. If you learned something interesting or new or helpful, we hope you share what you learn on social media. We have 3 fun hashtags we're using: CCIH 2022, faith-based, and global health. So we're so glad you're here, and we hope you're introducing yourselves in the chat box. And I'd like to turn it over today to our moderator for the session, Dr. Priya John. Dr. John is the General Secretary of the Christian Medical Association of India. And prior to that role, Priya worked for CMAI in the Community Health Department, and she's worked in palliative medicine in New Delhi for 3 years before coming to CMAI. We're really grateful that Priya has joined us this evening from Delhi, and thank you for moderating today's session. So over to Priya.
Thank you very much, Mona. And before we begin, may we just close our eyes for a word of prayer. Our dear Heavenly Father, we thank you for this time. We thank you for technology that connects. But more importantly, we thank you for the sovereign God that you are, who gives us standards of quality, standards of whole person care in so many examples when you walked this earth. And we just want to learn from you, dear God, as our teacher for today. Be with each person present here today, be with each one of the speakers. And we commit CCIH's conference, each of its sessions, and all the learning into your hands. Bless this time. In Jesus' name we pray. Amen. Thank you all for joining us today on this 5th day of the CCIH's annual conference. Now, each day they've been focusing on a theme of learning to love our neighbors. And today's theme for day 5 is quality of care, improving services for the whole person in times of change. When I saw this topic, the overarching theme of learning to love our neighbors, I was reminded of our Sunday school sketch we did on the Good Samaritan. And it ended with the question, who is your neighbor? And the answer is everybody. Everyone is our neighbor. So when we look at the word quality, quality is defined differently for each of our neighbors. And it is our duty and our privilege to meet them at that point of need and that point of definition. As we listen to our speakers today, we have a power-packed session for you all on this fifth day of the conference. We have interviews, we have insights from leading global faith-based NGOs. We have a panel discussion on a project experience, both in infectious as well as non-communicable diseases. We have maternal and child health discussions. That is one of the most important services our faith-based organizations provide. And of course, the whole area about supply chains. As we listen to the sessions today, I would encourage each one of us to be thinking about our discussion questions. As you can see on the slide that is projected, there are 3 rooms, and in each of the sessions, the interviews and the insights, etc., we'll be looking at these 3 different topics. So what are the questions? Different roles. What are the roles of clients, providers, and suppliers in defining and improving quality of care? The second is accountability for quality. How have you held your organization, project, or program accountable for quality of care in a facility-based or community-based program? And the last one, resources and tools for quality. What resources, tools, or data have you used in training? And today, we will start our day hearing from Dr. Sodzi-Tettey of the Institute for Healthcare Improvement. And Dr. Sodzi is going to talk about quality in all contexts, standards and measurement for quality of care for clients, providers, and supply chains. To introduce Dr. Sodzi, he is an MD and an MPH and the Vice President of the Institute of Healthcare Improvement, or IHI. He provides strategical, technical, and relationship guidance for all of his institute's work in Africa, which also securing new business opportunities in the region. And he's also had a role as the Senior Technical Director, Africa, leading Project Fives Alive in Ghana. And he serves on the governing board of Ghana's National Health Insurance Authority and the Council of the University of Health and Allied Sciences. So thank you very much, Dr. Sodzi, for joining with us today. And as we have this time of interview with you, I have the privilege of asking you a few questions. May I start with the first one? Okay. The first one, yes. The first one is, you are holding a very important position in a very specific organization related to today's topic. So can you please outline this Institute for Healthcare Improvement's approach for quality of care standards and measurements, and what is your learning in your experience? Over to you, Dr. Sodzi.
Thanks a lot, Priya. And I just want to say that it's a privilege to be part of this important conference, not least because I started my journey in public health and in quality improvement specifically 13 years ago in the National Catholic Health Service. So it almost feels like I'm back home, and it's a very comfortable feeling that I have. IHI has been leading global quality improvement for over 30 years, and we've worked in Africa and in many other parts of the world. So it's good to be able to share some of the experiences. And to get straight to the point, there are a few things that I can reflect on. One being that it used to be that when people spoke about quality, they thought just about the inputs. They thought about making sure that medical products and supplies are in place. It used to be that people would focus on the standards. Have you met these basic minimum standards, and so on and so forth? I think the lessons, as I've worked in this area for over a decade, is that it is not one or the other. You need different approaches. You need to be able to take account of the policy environment. so that at the high political level or within the leadership space, we are making provisions to be able to create the conditions that nurture quality of care. And then there's also that all of that will be under quality planning. And then there are also the interventions that help with measuring standards. Do we have the right protocols in place? Are we deploying the best evidence base to manage the various conditions that are accounting for our morbidity and mortality? And do we meet the standards in terms of staffing norms and all of that? All of those things will fall under quality assurance. And then there's more recently some conversations around quality improvement. These are team-based approaches where we will then focus on root cause analysis, rapid cycles of tests of improvement, and then applying the ones that have worked at scale. So I think that the key lesson is that we need to embrace a broad view of quality. The second lesson that I'll reflect on has to do with the fact that often you would find out that as people, outline a vision to improve the quality of care, it will be focused on only a small part of the health system. But I'm sure you're aware that as we talk about the broad network of CCIH and the various Christian associations that fall under it, you want to be able to achieve impact at scale. So this is where we have worked to be sure that the lessons from a small part of the health system are codified and are rapidly scaled up and also integrated within the health system so that we can have effectiveness that is scaled up and that is also sustained over a period, because you do not want a situation where an international NGO or a local partner becomes the driving force for the quality. You want the health system to be capacitated to be able to drive work forward. The third point has to do with data. And in many places, virtually in all places that we've worked, it's sometimes interesting how managers are often complacent in the quality of their data systems. But the reality is that in many places, we have gaps in completeness, in accuracy, in timeliness. So the reflection being that whilst it is good to work through routine data systems, it is equally important to pay attention to improving the quality and the reliability of these data systems. And I think that makes a lot of difference. The fourth lesson that I would reflect on has to do with building capacity. So sometimes people don't seem to realize or acknowledge that quality improvement and the methods and approaches that are deployed is a science on its own. So people need to be taught on what tools to use to do a root cause analysis to understand the performance gaps that they're experiencing. People need to be taught about a systems view. People need to be able to be appreciative of the patterns that emerge in data. And last but not the least, the psychology of human behavior, because you're dealing with people, you're dealing with teams, how do you motivate staff, and so on and so forth. So it's a whole science on its own that it's important that we teach people at various levels. So leaders would go for something specific, middle managers and frontline workers, and all of these things are critical. So we need to build capacity in a sustainable manner. And we then at the later stages will talk about how you build this capacity in pre-service and then also post-service, so that even as you train a new generation of health professionals, they have the requisite skills to be able to do this, as opposed to what you just do in the in-service curriculum. So that's very important to focus on. And as you learn these skills, there are things about setting ambitious goals, using rapid cycles of improvement to learn about what works in your system, adapting it, and then scaling it up through the entire health system. So what I've found is that it sounds difficult when you want to be able to drive outcomes, as in you want to improve the conditions that people are facing, you want to reduce mortality and all of that. But it is possible using the tools to be able to come up with a package of what works, and then we can then scale it up through the entire CCIH, for example, because the network already exists, the capacity already exists, and there's a way in which this can be done. So these are some of the quick reflections that I have at the moment.
Thank you, Dr. Sodzi. I think importantly, what you have talked about is I like the way you talked about effectiveness. When we talk about quality, we're always talking about systems, protocols, and therefore efficiency. But you have gone one step forward and talked about effectiveness to ensure that capacity is built at all levels, and it's a system, which is ingrained in all the staff. So thank you for that. Next question is regarding, now we have a system that works, it's efficient, and now we're looking at effectiveness. How do you secure stronger engagement by the community in partnership with health facilities and the medical workers to improve this quality of care? Any thoughts?
That's an interesting question. And I've done some work with colleagues at the WHO, and the head of their patient safety program made a point that was very striking to me. She said that, well, we can do all of the things, improve the standards, work on the protocols, but the one thing that is most critical in driving the quality is to stimulate demand by activating the involvement of patients. Because if patients are empowered and they're demanding for high quality care and they're demanding for better interactions in their work with health professionals, we are put on our toes at once. And I know that as health professionals, sometimes we are not comfortable because it's like you are empowering the patient against us. But right now the conversation is shifted into a very shared partnership where patients really need to be brought front and center into the conversation. And the first thing is when we are mapping out the policy process, when we are setting the quality agenda, even at that stage, it is important to bring the community into the conversation. So the end recipient should be part of co-designing the care process. So in some places where we work, we would have all of these focus group discussions with patient advocacy groups, hearing from them and reflecting their concerns in the policy. Sometimes there's a parliamentary select committee on health. You make sure that they are involved as part of the accountability mechanisms. And so there are various ways in which this can be done. And so once we've involved them in the planning, there's also the implementation. And in many places where we've worked, within the quality policies and strategies, they would make provision for quality management teams to be formed at various levels: community level, facility, district, regional, and then national. And what we are doing increasingly is to make specific provision for community actors to be part. So if you're dealing with mothers and newborns, let them be part of these quality teams. And it should not be done in a tokenistic manner, but because we really treasure their views in the way in which things can be done. And that's also a very key thing, to invite them to be part of the condition. And then the third thing has to do with various tools that people have deployed. So there's a community scorecard, for example, where communities meet and they give feedback on the quality of care, and the measurement is integrated into the national data set. So we know what the community thinks, they come up with shared solution, and then they run forward with them. And the last bit will be some intervention in Mozambique, where there's an SMS platform where patients come to the facility, their views are sought, and through a blast SMS that goes out, this is quickly analyzed and fed back into the work being done by the quality teams and also by the senior managers. That way, we know what the community thinks, and we can have an opportunity to respond to it together with them. So the key thing is that it is important now to really work closely hand in hand with patients and the communities. Over.
Thank you very much, Dr. Sodzi. I think the whole idea about participatory evaluation, that is something which is very, very important. And I remember one of our projects in the field level where we brought in the women to talk about what they wanted. And just listening, just to give them a platform to talk was so important. And when they give their feedback, it makes a lot of difference on even the cost effectiveness of any program that we run. Because if we make the wrong decision and put in the wrong money in the wrong thing, it's not useful. So thank you for that. Any specific tools that you would like to share with the participants? Dr. Sodzi, anything in which you would like to put on the chat box or any
So
other
I'll put together
names?
a quick mock-up of tools and that I would share with you. There are things about the scale-up framework. IHI.org has a number of white papers that talks about these. So I think I would lead you there. There are a whole number of tools. We have an Ubuntu newsletter that we publish every month that harvests stories from across Africa, for example, what people are doing in their small settings to improve care. And there's a session that focuses on quality tools that people are finding useful. So I would just pull out some of these things and share with you.
Yes, so thank you, Dr. Sodzi. Would you like to give, maybe you have a minute or two for any closing comment if you'd like to give? Or
well,
just
what I would
advice?
say is that for me, it's refreshing that I'm in a meeting where we are starting with prayer. It seems like that is not very popular in the world in which we live, you know. So it's good that we have like-minded people who are mission-oriented and they're doing this because I am also a Christian and I'm inspired by what you're doing. I also want to say a big thank you to Doug, who I've been listening to on the work that we are doing globally. So I'm very happy to be here and happy to support whichever way.
Thank you, Dr. Sodzi, and I totally agree with you 100% on that note. So thank you for this time of interview and for these questions and for sharing the tools. And we wish you all the best in your work as you continue to improve quality.
Thank you.
Okay. So now we will go on to our next speaker. And we have, as CCIH, we are very grateful for our sponsors who have helped to make this conference possible. And as you know, we have made this conference free for all our low and middle income country participants. But running even a virtual event is far from free. So we are very grateful for all our sponsors, especially our platinum sponsors. And so now today we will hear from World Vision, a longtime CCIH member and supporter. For the talk, we have Leticia Nkonya, a PhD and a technical advisor for gender equality and social inclusion. She is at the World Vision USA. She's a published researcher with more than 20 years of experience and leads the GESI Transform project that focuses on GESI integration capacity building, strengthening evidence of impact and promising practices. Leticia, thank you for being with us. And I will hand over this time now to you.
Thank you so much, Priya, for the introduction, and hello, everyone. I'm really excited to be here today and look forward to today's discussions. As a faith-based organization, World Vision is committed to improving the lives of most vulnerable children and adults. We are continuously looking for ways to improve the quality of care to all the people we serve in many countries around the world. We realize that one of the barriers in serving the whole person is the lack of utilization of gender equality and social inclusion tools and resources to be able to systematically reach and serve the most vulnerable and incorporate their needs and perspectives in our programs. We also wanted to be able to document and communicate knowledge and learnings as we continue to improve our services. So we developed what we call gender equality and social inclusion approach, also known as GESI approach, that we use as a framework to promote transformational change along the 5 domains of access, participation, decision-making, systems, and well-being. In serving the whole person, our GESI approach looks at all the 5 domains I just mentioned. For example, when it comes to access to quality care, we want to know who has access and who is excluded from that access and why. What are the root causes of inequality and exclusion? What are the needs of the most vulnerable, and how can we best address those needs? We conduct what we call just assessments to be able to understand these issues and incorporate the findings in our program design and implementation. We also understand that access to quality care alone is not enough. People need to have the ability to participate and make decisions on the care they need and what works best for them. So we use different empowerment approaches that we use to empower them to do that. We also look into systems, both formal and informal, because we believe that inequality and exclusion are often linked to unequal systems, and that's also connected to existing structures and social norms and the relationships. We try to challenge those and address those that tend to exclude some groups or individuals. So you will see on the screen that our GIST approach emphasizes change at 4 levels of the ecological system. So we have the individual level, household, community, and societal levels. When we improve the quality of care for an individual woman with disabilities, for example, we want to know how that change translates to the well-being of a household, community, and society in general. So we also look into intersectional and overlapping vulnerabilities, and we try to address those. Our goal is always to improve the overall well-being of the whole person, the spiritual well-being, economic, emotional, and psychological well-being. So we believe that without equality and inclusion, the well-being of most vulnerable individuals and the groups will not change in the long run. So I welcome all of us to look into those 4 levels and also try to figure out how can we best incorporate the best practices in our program so that we can serve the whole person and improve their overall well-being. I'm really honored to be here today, and I look forward to learning more today. Thank you so much for the opportunity.
Thank you very much, Leticia, and thank you once again, World Vision. For our next area of discussion, when we go into our breakout rooms, we're looking at accountability, and projects are definitely areas where our accountability is tested, whether it's to the donor, whether it's to our own staff, or whether it's to the community that we serve. For our next panel discussion, we have important and experienced speakers, all from Malawi, and they are representing various aspects of a PEPFAR program. We will hear from Peter Chalusa, who is a project manager for the World Relief Strengthening Community Outcomes through Positive Engagement, SCOPE for short, in the HIV team in Malawi. We will also hear from Pirira Cathy, who is the Executive Director of the Malawi Interfaith AIDS Association, and from Khama Daudi, who is the District HIV Testing Services Coordinator for Machinga District at the Malawi Ministry of Health. So good combination of speakers for this panel discussion as we look at their experience in this project or the PEPFAR program in HIV. So may I now hand over for this session to the Malawi panel.
Welcome to this panel discussion for the abstract that World Relief presented regarding quality of care for people living with HIV in rural communities in Malawi. My name is Peter Chalusa. I'm the project manager for SCOPE HIV with World Relief Malawi. With me here, I have got Mr. Khama Daudi, who is an officer from the Ministry of Health. But also I've got the madam here. She will introduce herself.
I'm Pirira Ndaferankhande, Executive Director for Malawi Interfaith AIDS Association, MIA.
Thank you very much. So in this discussion, we are going to share with you the work that World Relief has been implementing in Malawi in the 3 districts of Lilongwe, Mangochi, and Machinga. So this is PEPFAR funded work funded by the USAID Malawi mission. Specifically, this is addressing gender as both a driver and a barrier to Malawi's achievement of the HIV epidemic. As you know, the HIV prevalence in Malawi is around 10.5%. And of course, of late, the number of new infections has dramatically gone down. And there are now specific key groups that having higher new infections. And the scope HIV was specifically designed to target these groups, especially young men and boys. So I will talk a bit about the scope HIV, and then I also ask my colleagues to contribute on their contribution as key partners in this work. So the scope HIV project started in September 2020. Of course, the work plan was approved by the USAID mission in October, and the main activities started in December of 2020. So we are now in the final year, and we'll be completing this work in September 2022. So far, the project has supported the creation of several groups in the communities where we're working, which includes identifying and recruiting volunteers who are helping with supporting different groups in these communities, especially in tackling gender-based violence. So World Relief has played a role of coordinating this work, making sure that all the key players in the communities are working together, but also making sure that the government structures are aware and participating in this work, and also making sure that our key partners such as MIA, but also Ujamaa Pamodzi, are also working with us very well. So before I go any further, I would like to ask Mr. Khama Daudi just to share a bit the role that they have played as government in this work.
All right, thank you very much. Our role as Minister of Health is our policy guidance. We provide policy guidance according to the national standards. For example, training of our providers. We make sure that the providers are trained according to national standards, and also coordination among the implementing partners in the district, and also monitoring and evaluation. The HIV providers, they need to be monitored and evaluated, like supervisions and mentorship for quality service delivery. With that, I think we work hand to hand with the implementing partners in the district, so that all together we achieve the ministry's goal. Thank you very much.
Thank you. I think that's very important. You notice that when we started this work in these communities, where HIV testing services were not very much present in these rural communities, we worked with the Ministry of Health to make sure that we recruit volunteers who are trained as HIV test kit distributors, and they were able to do that. In addition to this, we have also worked with MIA. MIA will also tell us the role that they have played in this work, especially in coordinating the faith groups in these communities.
Thank you very much. As MIA, we have worked closely together with World Relief in issues of capacity building, periodic reviews, and monitoring. Our role basically has been on trainings on SASA. As you know, HIV is spread because of some major reasons, being gender-based violence, poverty among women, and also issues of power relations and poor economic standards of women. So SASA basically looks at how to eradicate poverty among women, that's economic empowerment, and dealing with GBV, which comes because of power imbalances that comes from masculinities among men, And also we want to eradicate HIV by removing stigmas that prevent people from taking ARVs and getting HIV tests. So we've been connecting the faith community, religious leaders, to the structures of SASAFE using district interfaith AIDS committees. And we've been providing facilitators, and we've seen structures being strengthened, community activists finding their peers and discussing issues of HIV in several social gatherings, in the church, in the mosques, at football centers, and in all areas where we get people. And we have seen gender-based violence being reported and being reduced. And we've seen a lot of men going for HIV testing. And because of that, we've also connected the women groups to social welfare and to structures of village savings and associations where we're looking at empowerment of women economically. So with the faith community, they have realized that some scriptures from the holy books, the Qurans and the Bible, they perpetrate gender-based violence. So our religious leaders have been looking at these scriptures and analyzing them and find ways of how they can use the holy books in dealing with HIV issues and dealing with gender-based violence in the faith community. Thank you very much.
Thank you. I think that's very exciting to hear. So, in this discussion, we would like now to focus on how this work has ensured quality. And I would like to ask our counterpart from the Ministry of Health to share with us in terms of what steps have we been taking to ensure that the work that we are doing is of good quality, is contributing to quality based on Ministry of Health standards.
All right. Thank you very much. Quality is paramount in service delivery, especially in HIV service provision. You know, in the districts, we have promoting, quality service delivery in the way that providers receive standard formal training. They need to be undergo a formal training according to the national standards. After that, when they are providing the services in the community, we need to evaluate. That's monitoring and evaluation. We do supervisions, mentorship. You know, we check the M&E tools, how they're using, and whenever there are gaps, we mentor them so that the service delivery is of good quality. And also, we do review meetings. You know, we call them, then we discuss about the issues and the like. And also, we advocate the coordination among the health workers, you know, the community workers and the health workers, they facilitate the health workers because they need to link each other. They need to coordinate to each other in the linkage and some areas.
Okay, thank you for that. One of the key things that we've ensured as a project is to make sure that in addition to creating demand for HIV services through preaching the messages of hope in congregations of prayer, we also noted that, of course, we've preached to these people, they come forward for testing, and then from there, we make sure that, for example, those people with who needs HIV testing, after hearing the messages of hope, they are able to go for testing. We've reached over 400,000 people with messages of hope over the past 1.5 years, but we have also, through that, managed to reach out to people with who have survived gender-based violence, and so far we have had close to 2,500 people who have been assisted. But we noted that there was a gap because in most of these rural communities, most of these survivors were not supported with any psychosocial support. So we were able to recruit, to identify some faith leaders, 274 of them, that we trained through an approved, a government-approved package in psychosocial counseling. So these people are now able to provide basic counseling to survivors of gender-based violence in the communities. We think this is also one way of contributing to quality of care in these community services, because for many years, for a long time, people were not able to access these services in these very rural communities. I would like to extend the same to Mia in terms of through the SASA Faith package. What will you say as some of the things that this work has also contributed on quality of care as regards to these very rural communities that we have worked with?
Thank you very much. To ensure quality, we've been working together with World Relief in terms of monitoring, the dialogues and the periodic reviews, where we take everybody that is a stakeholder to be taking part in the reviews and giving out what has been working well and what needs to be done better. And in Malawi Interfaith AIDS Association is represented in the technical working groups. Our religious leaders, the ones that are working with the SASA program, they are also in different technical working groups at district level, where we present whatever the faith community is doing, and from there we get recommendations from the government stakeholders. We have also worked together with the National AIDS Commission, and Mia is a representative of the NPF, Malawi Partnership Forum, which is an advisory body of a National AIDS Commission. So in these forums, we are able to present whatever the faith community, and that's including what Relief has been doing in the response, in the faith-based response against HIV and AIDS. And through these technical working groups, we are able to make sure that whatever outcomes are coming from the project are feeding in to the outcomes that are needed for the organizations as well as for the nation of Malawi and the global goals in the fight against HIV and AIDS. Thank you.
Thank you.
Thank you very much, Team Malawi and the panel, giving us your insights and learning from the PEPFAR program as you looked at a positive engagement to tackle HIV. It's very important to bring different partners together as we look at national level projects. And this example from Malawi is an excellent one where they're bringing in different forums at different levels, as well as the government. And as we prepare to listen to our next speaker, it's just to reiterate what Mr. Khama Daudi said about supervision, M&E, mentorship. And these are important areas. And as we listen to our next speaker, Dr. David Balikitenda, David is a monitoring and evaluation specialist at the Uganda Protestant Medical Bureau. And we are going to hear about a non-communicable disease project in Uganda. And we look forward to hearing his experiences in this whole area of M&E in a non-communicable disease. Over to you, Dr. David.
Thank you so much. I'm glad to be here and to share how documentation and measurement of outcomes lead improved quality of care for non-communicable diseases in Uganda. Next slide. Uganda Protestant Medical Bureau, or UPMB. It is a national umbrella organization that was started way back in 1967 to serve as a technical arm of the health facilities affiliated to the Anglican Church of Uganda, the Seventh-day Adventist Church Uganda Union, and the Pentecostal churches. 80% of these facilities are in the rural communities. Currently, we have a total of 312 member health facilities and 16 health training institutions. 19 of them are hospitals, 10 are health center 4s, those are mini hospitals, 157 are health center 3s, and the lowest level being 126 health center 2s. We are scattered across the entire country. Next slide. As an organization, the current strategic plan prioritizes research and development for strategic centers of excellence, focusing on non-communicable diseases, including mental health. Next slide. Why non-communicable diseases? Of course, the increasing trends for non-communicable patients in the UPMB member health facilities. Most of the patients would come late with complications, and they were overwhelmed with treatment costs for NCDs. However, important to note is that NCDs are largely preventable. Next slide. A look at interventions by UPMB for non-communicable diseases are currently being implemented across 35 project sites in 4 regions and 17 districts. The intervention focuses on empowerment of health workers and the village health teams or community workers with knowledge and tools, that is capacity building to screen and link patients for both hypertension and COPD or asthma. Of course, there is also demand creation through awareness raising on health lifestyles, also focused on availability of a variety of affordable and quality medicines. That is for both hypertension and COPD or the respiratory. And this is done through the joint medical stores. Of course, the fourth component is a clear referral pathway to decongest the high level facilities, especially when it comes to monitoring and drug refills. And overall, this will contribute to the prevention and control of hypertension and COPD and a decrease in the burden of cardiovascular disease. Next slide. Of course, for demand creation, we relied on district health officer, the platforms at the districts, the platforms provided by the religious leaders, including the bishops, as well as the diocesan health coordinators. This was backed up by the community health workers or the VHTs, as well as the logistical and medical teams at the facilities, but also through GMS and UPMB. Next slide, please. Of course, as some of the outputs delivered by the interventions by UPMB, 35 project sites established NCD clinics through which 2.3 million people were screened for hypertension, of which 691,000 had elevated blood pressure. That's about 28.5, which is within the rate for the Uganda elevated BP range. conducted 13,000 sensitization sessions, through which 1.9 million people were reached with information on hypertension, and 500,000 people were reached with information on COPD and asthma. Screened a total of 359,000 and for COPD or asthma, of which 38,000 had a reduced peak flow reading, and that is about 11%, which is still within the rate, prevalence rate for asthma within Uganda. 15 of the 35 sites had an improved variety of NCD medicines, including newer molecules. These are just the outputs that were conducted in terms of capacity building and equipping sites. Next slide. Of course, UPMB uses the community health insurance as a sustainable mechanism through which 15 of the 35 sites were trained in community health insurance. These incorporated non-communicable diseases. Initially, it is important to note that non-communicable diseases, due to their chronic nature, were excluded from insurance packages. But with the intervention, these were included, and a total of 2,998 people accessed NCD care through the schemes. Generally, the insurance improved health-seeking behavior and the timeliness. Next slide, please. The intervention also improved documentation and reporting. Initially, health workers were not documenting blood pressure readings, blood sugar readings, the body mass index for the patients. However, with the intervention, each patient has his or her reading documented, and those with that are diagnosed with hypertension or COPD asthma had a file established for them and given a unique identifier as a patient number. And this improved the efficiency and planning for hypertension, as well as a patient having to spend less time, and as well as increased availability of medicines. Next slide. Thank you.
Thank you, Dr. David, for those keen insights into managing a project for non-communicable diseases. Documentation and reporting has always been, our weak points, as especially in our faith-based NGOs in our country. It's not easy to have a good documentation process ingrained into the system. But thank you for giving us some insights and some inputs into that. And we look forward to your experiences and your learning in improving the quality for NCDs. Just a quick reminder to our participants. Yeah, thank you. Just a quick reminder to our participants, please do put your questions in the chat box or wherever it is suitable for you. And we also, there are the toolkits that have been shared in the chat box. Do take down the links and use them for your various activities as we learn on improving in our quality and our systems. We now look forward to our next speaker. This is an interview that we will be seeing. We have an interview between Kasande and Chris Prenger. Dr. Chris Prenger's 30 years of experience include on the Navajo Indian Reservation in Shiprock, New Mexico in the 1990s, And Dr. Chris began work in Bangladesh in 1997. Now, what we're going to hear is from a nursing student, Kasande, about her work in Uganda in care for people living with HIV. Kasande is a fourth-year nursing student at the Bishop Stuart University in southwestern Uganda. So over to Kasanda and Chris.
So what was your research study?
My research question was to determine the proportion of adult HIV patients living with HIV in southwestern Uganda, and we also wanted to assess the factors associated with retention in care among adult HIV patients in Uganda, in southwestern Uganda.
So who did you interact with to collect information, to collect your data?
We interacted with 3 groups of people: the providers, the CLAD leaders, and the CLAD patients.
Can you describe the CLAD groups? How were they organized?
Well, these groups comprise of 5 to 6 stable HIV clients, and they are headed by a group leader. And how to choose a group leader is if a person has been living with HIV for more years than the rest and they're not stigmatized about HIV, they can easily disclose. That's how they choose the group leader. And in these groups, they alternate when it's time to pick drugs, when it's at clinic day. And when that person picks the drugs, they gather at some point or at a member's home, and in the evening they distribute drugs. And when they're distributing drugs, they always talk about the different issues affecting them. They do the peer advice to each and every member, and that's how the groups do work, and that's how they are formed.
So can you give a little bit of the findings? There were many interesting findings from your research. Can you tell us some of those findings?
That is very true. The findings were so interesting. I also liked them. And according to the study, we said we got the findings like 98.1% were virally suppressed. And patients say that this was due to the benefits, experiences, and perceptions. Among the benefits which favored them was the peer advice. They said that during these meetings to pick drugs, they always got advices from the members, the fellow members. They also said that they received counseling from the health providers about how to adhere well on drugs. And then in the experiences, they said that it was a good experience. It was a good experience since they adhered well. And in the perception, they say that it kind of reduced stigma because at some point, some members refused to go to the facility, but now they can easily go. So it was really good for them, for the patients. And then on improving the quality of care, the health workers say that before they would attend to so many long queues of people who wanted the drugs. But now just imagine, out of 50 people, only 20 people are coming. Even the health worker who is working on these patients, they will have the energy and they will work on these patients with energy. It won't be like before. I'll give an example. When we are in the hospital, we always work on so many patients, and by the time you're in a half day, you're already tired and exhausted. But now, since there was this innovation, it kind of reduced on the so many people to work on, and this improves the quality of care in that way.
So it sounds like reducing the long lines at the facilities and allowing the providers an increased amount of time with patients has a wonderful benefit.
On the facility, you do not get enough time to look into one patient and you talk to them effectively. So if these models are implemented in all parts, not only in HIV, they would literally improve the patient's life. or care that is given to them.
I think that's a wonderful background on how this particular mechanism improved the quality of care, the quality of your education, and I really thank you for sharing your results with us today.
Okay, thank you very much, Doctor.
Thank you. Thank you very much, Chris and Cassandra. I think it's very important what was the research question, and how talking about the outputs actually bringing about a fantastic outcome by a simple intervention. And I hope all these projects and these studies, research papers will be available for us to learn from and improve our systems in small ways so that the outcome can be quite big. As we look at continuing, to hear about quality improvement, we're going to hear next from the latest best practices for helping women after birth or post-abortion, and also able to safely time pregnancies to avoid problems in the future. So as we listen to postpartum and post-abortion family planning, the topic which is timing is key for quality, we are going to listen to our two speakers. One is Dr. Douglas Huber, who has 40 years of experience in international health, and it provides him much wisdom to serve as CCIH's Senior Technical Advisor for Reproductive Health. We also have Tembe, who is a Zimbabwean nurse, midwife, and public health professional, and serves as World Vision's US's Senior Technical Advisor for Reproductive, Maternal, Child, and Adolescent Health and Family Planning. So over to you, Dr. Douglas and Tembe.
Thank you, Priya. This is, I'm delighted to be with you this morning, this afternoon, or this evening, wherever you are. CCIH and CCIH members have long championed the concept of healthy timing and spacing of pregnancy and the importance of that for women's and children's health. And here's a few pointers for how timing can be appropriate and improving the outcomes and the efficiency of services. Next slide, please. Having an abundant life as Jesus has brought himself to our world includes in reducing neonatal, infant, and child deaths through healthy timing and spacing of pregnancy, and also helping women who have had an abortion avoid the next one through preventing abortions with reproductive health practices. Next slide, please. Just how strong this effect is illustrated in this slide, where we see that neonatal, infant, and under 5 mortality is 2.5 to 3 times higher when pregnancies or births are spaced less than 18 months compared with 3 full years at 36 months. So these are important aspects and to help women to achieve the spacing that they want. Next slide. We find out that demographic and health surveys have shown that 95% of women in the first year after giving birth want to space at least 24 months before having another pregnancy, but only 30% are using an effective method that will help them achieve that spacing that they want. We also know that after an abortion, whether it's a spontaneous miscarriage or an induced abortion, that fertility can return within 2 to 3 weeks And that is often not known to the woman and not even to providers, that fertility returns too soon. So to help her avoid the next unwanted pregnancy, one needs to act in a timely fashion at the time when a woman is at the facility. Likewise, postpartum fertility can return 3 to 6 months, even with breastfeeding if the woman is supplementing early, which is a very common practice, even in low resource settings. And we know also that when you do provide quality services, that the acceptance is high. Next slide. We also see that it's the same providers, nurses, midwives, and doctors who care for women in their postpartum, as well as the post-abortion period. So treating women who have had either a spontaneous abortion, miscarriage, or are suffering from complications of abortion, these are the same providers, and training in immediate services, whether postpartum or post-abortion, has some useful overlaps for gaining confidence and competence, as well as the logistics and systems which one uses. And when one provides a choice of contraception, 20 to 50% will typically leave the facility with a method of their choice, always ensuring voluntarism. Next slide, please. Oh, go back one period. This illustrates in these numerous countries, when you provide post-abortion clients with the option of a contraceptive method, the acceptance rate is high before leaving the facility, between 70 and 85% in these countries. And the variety of methods is quite broad. It may include predominantly pills in one country, injectables, implants, or as you can see from the slide, a variety of methods that are often accepted. So a range of choice is often very important. Next slide. This gets into a rather difficult area in conflict areas now that the world has achieved more than, sadly, 100 million refugees in the world. These women are some of the most vulnerable in places like the Democratic Republic of Congo, Somalia, and Yemen. Save the Children has demonstrated that the uptake is high, and this includes some of the long-acting methods. Next slide, please. So I'd now like to turn it over to Thembi to talk a little bit more about the elements of quality. Over to you, Thembi.
Thank you, Douglas, for providing that background of why post-abortion family planning and postpartum family planning go hand in hand, and why they are so important in saving women and children's lives. I will summarize what one of the earlier speakers, I think it was David, who talked about quality of care in general and what constitutes quality of care. And I would like to summarize what the World Health Organization says about quality of care, that it should be effective and efficient, it should be timely, it should be acceptable both to the user and the provider, it should be client-centered, equitable, holistic, that is integrated with other services, and it should be safe for the users. I am therefore going to talk about this slide from a demand side perspective, the supply side perspective, with a focus on the provider and also the environment in which the services are provided. On the demand side, I think I want to emphasize that clients will only ask for what they are aware exists. And therefore, awareness is very important. But beyond awareness, they have to recognize the benefits to their individual selves to their families of that service that is being provided, and that the service is available, it's safe, it's respectful, and it's not biased, and that they generally enjoy a positive experience of that service that is being provided. But more importantly, that the decision to accept or not to accept, to postpone service acceptance is entirely theirs, is voluntary, and is purely voluntary. And that when they make decisions, whether to accept postpartum or post-abortion family planning, that the decision, whatever the decision they make, will be supported in that environment, and that their concerns will be addressed, that it will only not be about providing contraception, but also linking them to other services. For postpartum family planning, for postpartum clients, it will be breastfeeding support, it can be nutrition support, it can be also linked with child immunization services. For post-abortion clients, can be linked with services such as HIV, sexual and gender-based violence, to make the services holistic. Coming to service providers need protocols. I think the issue of protocols was brought up, but the protocols have to be evidence-based, have to be very explicit what the client or what the provider should do for each individual client, from the young adolescent client who comes in for postpartum family planning or for delivery. And that there should be capacity building, and the capacity building of service providers should focus on their knowledge and understanding of things like return to fertility, the physiology of pregnancies, why some pregnancies go to term, why some pregnancies don't go to term, issues about healthy timing and spacing of pregnancies. We need to build capacity for their competencies to counsel clients in a non-threatening environment, to also provide whatever method the client has chosen, and also build their attitudes towards empathy, sympathy, non-bias, and discriminatory services. And these competent service providers need to be supported, need to support it for continuous learning, need to be supported to provide services with updated guidelines, with updated knowledge as it comes. I'm going to touch a little bit about the environment in which the services are provided. For the client, we already talked about safety of services, but including or hand in hand with safety, we need to consider the dignity. We need to consider privacy. We need to consider that client needs to walk out, not just with the contraceptives, but also with the positive experience for the services that have been provided, with their concerns having been adequately addressed. For the service providers, the environment needs to be supported with continuous mentorship and supportive supervision, the right equipment, the right range of supplies available in the right place and in the right quantities for them to be able to do their job effectively and provide services efficiently. For postpartum family planning, most of the equipment that we find for post-abortion care, the same ones that are provided within the family planning setup. But for immediate postpartum family planning, you need to modify that equipment, you need the long forceps, and you need to be able to provide that immediately. I will look a little bit at timeliness of service provision. Next slide, please. Information, generating awareness, not just about issues of pregnancy and contraception, During the preconception care, we need to look at issues related to healthy timing and spacing of pregnancy and what that means to various clients, HIV services, GBV services included. But creating that awareness that if they have or they can opt for voluntary family planning if they so wish. Counseling should continue throughout during each antenatal visit, because childbirth is not the time to make decisions or whether they want a contraceptive method or not. Like somebody said, or if we ask women to make decisions at childbirth, everybody will say, yes, I don't want another pregnancy immediately. Again, counseling about family planning and other maternal health services or reproductive health services should be part of comprehensive post-abortion care at treatment and management of abortion complications, including a post-abortion checkup. Continuity of services should be at postpartum checkup, whether it's the 24 to 48 hours or at the 6 weeks checkup. And opportunities present themselves during child health, during immunization and growth monitoring. But the emphasis is that every contact with a client who is within the reproductive age group should include messages about their reproductive health and should include messages about ultimate maternal health. And up to 24 months after childbirth is where actually the postpartum family planning ends, which is that window where a next pregnancy, if it occurs, is healthy. I'll go to the next slide, please. There are different methods that are available in different, at every stage of pregnancy, and I will not go into them. There are methods that can be given at immediate postpartum or immediate post-abortion, including lactational amenorrhea, male sterilization, female sterilization, which can even happen before. We also have intrauterine contraceptive devices available at immediate postpartum, including 4 weeks after delivery. Oral pills, Douglas talked about acceptance of oral pills within the post-abortion, postpartum family planning, and fertility awareness methods for women that so wish, or barrier methods like diaphragms, condoms, also for women that so wish and that provide dual protection against things like sexually transmitted infections. I will turn it back over to Douglas to talk about resources that are available for post-abortion or postpartum family planning. Thank you. Next slide.
Thank you, Thembi. That was a nice overview from the front lines of people who have been dealing with these things. I've put the main resources in the chat box. Resources for training and support are needed. There's two very nice overviews from USAID that both Thembi and I have been working on with our USAID colleagues and others. And they are in the chat box there for both postpartum, immediate postpartum contraception and how that can be done well in a quality context, as well as post-abortion family planning. So I'll leave it there. These are key points, as we all know, for the health of women and children. And there's partners that can be provided, including USAID and the Momentum project that CCIH is involved with that can also lend a hand. So thank you very much.
Thank you very much, Dr. Douglas and Thembi. I think it was a fantastic overview. Thank you for the statistics that you gave us, and thank you for those reminders about the WHO principles as well as looking at quality. We'll now go on to our next session, which is about strengthening faith-based supply chains, a discussion on USAID-funded Momentum Country and Global Leadership Project on Faith-Based Drug Supply Organizations. Our panel will include Carolyn O'Brien, Karen Hardy, and Naga Edward. I would now hand over to Carolyn.
Hello, my name is Carolyn O'Brien, and I am Project Advisor at CCIH. My background is in health system strengthening and community-based programming, and I've worked for CCIH for 2 years. I help manage our USAID funded grants and coordinate our health systems initiatives, including the 30 by 30 program and the Christian Health Asset Mapping Consortium. I'm also the liaison for the Community-Based Prevention and Care Working Group. Welcome to this exciting session, What We Need, When We Need It, Strengthening Faith-Based Supply Chains. I am very pleased to be joined by Karen Hardy and Dr. Nga Edward to discuss this important topic. Karen is president of What Works Association. She's a social demographer, expert in reproductive health, and gender and climate change. She is a member of and consults for CCIH. Most recently, she has been supporting the learning element of our Strengthening Faith-Based Supply Chains project. Dr. Edward is Central Pharmacy Manager at Cameroon Baptist Convention Health Services, or CBC. He is member of the board and the disciplinary committee of the Pharmacists Council of Cameroon. He is also the manager of CBC DFIAM COVID-19 project and vice chair of the board of the Ecumenical Pharmaceutical Network in Kenya. Dr. Edward is an expert in leadership and supply chain management. CBC was one of 8 faith-based drug supply organizations, or DSOs, that participated in the Supply Chain Strengthening Project through the USAID-funded Momentum Country and Global Leadership Program. It is well known that stockouts of commodities at the last mile is a common challenge, including in more than 8,000 health facilities managed by Christian health associations in Africa and similar networks in Asia, which have been documented thanks to a Reproductive Health Supplies Coalition grant. In years 1 and 2 of Momentum, CCIH leveraged our expertise at engaging FBO managed facility networks and partnered with McKinsey & Company to utilize their supply chain expertise to strengthen the capacity of the DSOs in costing, quantification and forecasting, and integration with the national supply chain systems. This work started with a supply chain self-assessment undertaken with the 8 faith-based DSOs in 5 countries: Cameroon, Kenya, Nigeria, Ghana, and Uganda. In year 2, 6 of those DSOs continued their learning by participating in a supply chain leadership development program virtual course. Currently, we are in year 3 of this program, and CCIH continues its work with the 6 DSOs in 3 countries to capture the learnings from the first 2 years and to create concept notes for further intervention to strengthen their supply chains. I will now turn it over to Karen Hardy, who will engage Dr. Edward in a discussion about CBC's involvement in this project. Thanks, Karen and Dr. Edward.
Thank you, Carolyn, for that introduction. And it really has been my pleasure to work with CCIH and get to know Dr. Edward and others in these DSOs working on this really important activity. So, Dr. Edward, I'd like to ask you. We've just heard Carolyn describe the Momentum Country and Global Leadership Program for DSOs, that both the assessment and then the leadership development program that came after the assessment. So I would just like to ask you, how has your organization benefited from being involved in both of these activities?
Thank you, Karen, very much for that question. CBC Health Services, the central pharmacy is the pooling agent for drug supply management, where we buy everything together, I mean, as a pool, and then we redistribute to our institutions. During the assessment of our supply chain, we discovered that there were a couple of gaps that even though we were working and thinking that we are doing well, there is still a lot to be done.
Mm-hmm.
And so by that, we saw that there were gaps even in transportation, in storage, and with the personnel, the level of knowledge of the personnel that is working on the supply chain needs a lot of improvement, especially about the cold chain. Then when we identify these gaps, we have started trying to see how we can put together some CAPAs and see how to work with them. That is the corrective actions and on gaps that have been identified. By that, the little improvement that have been done so far have brought a lot of benefits to the system already. And then the personnel gaps, the knowledge gaps that were identified, we are also working on bridging those gaps. And when that is done, it will add to the benefits that CBCL services has from this assessment.
Thank you. Thank you so much. And how do you think CBC will sustain these benefits once the project is ended?
CBC will definitely sustain this by doing a couple of things. The first thing is that by way of transportation, we discovered that there is need to add the fleet of vehicles that we are using for distribution. When this project comes to an end, if we have added, even like now, we have already added one small vehicle that can move around small consignment of goods.
Mm-hmm.
One of the things that we are ensuring here is that there should be preventive maintenance of the vehicles, the equipment the same. We are ensuring that there is going to be preventive maintenance. And if this happens, it will prolong the lifespan of what we have for distribution and for storage. So that will make it sustainable. By way of the person, we have planned some workshops that will help those who are on the supply chain. There are also long-term programs that are going for some for 2 years, some for 1 year, as a training of pharmacy technicians and pharmacy assistants. We are encouraging some of our staff to go in for these programs if they have sponsorship, because a number of them, even though they are qualified and they like to do the programs, they complain of sponsorship. So if we have some of them go in, like I'm talking now, some of them have already started the program. We just hope that they will be able to finish. If they do that and come back, that and join the workforce, that is going to go a long way to keep this dream alive. Thank you.
Great, thank you. Thank you so much. So what would you say are the remaining challenges that CBC faces in ensuring drug supply to the health facilities that you work with?
I think one of the key challenge that we have as a drug supply organization is the government bottlenecks. there are a lot of government bottlenecks when it comes to importation and even transportation of the imported drugs and medical supplies around the country. So if the government could release a number of requisitions, of requirements that they put up for importation and also for transporting of drugs and medical supplies around the country, that can go a long way to help us. The remaining challenges also are in the area of the number of vehicles that we have. Our system is growing, but the available vehicles are also getting older. They are fewer and older, and so there is need for replacement, but this is not easy. We also have challenges in the area of the cold chain. In particular, the CBC Health Services drug supply system, it is big. It is handling a good quantity of these keep cool items that have to be stored at 2 to 8 degrees centigrade, but we do not have a cold room. That is the starting point. We do not have a cold room. The second thing is that the fridges that we have are household fridges that have been adapted to keep drugs. They are not the WHO standard fridges for managing the cold chain. So those are some of the challenges. And in the area of personnel, the challenges that are still enormous, as I'm saying. There are people there who are ready, they are willing, they are qualified to go in for higher courses. Some are even qualified to go in and read pharmacy to serve better, but the resources, financial resources.
Wow, thank you, thank you. I have just one other question for you, and that is, if you had the opportunity to speak with a donor interested in supply chain organizations in Cameroon, what would you say to convince them that they should fund a faith-based drug supply organization to do that work, or to be part, but to be part of that work?
The first thing is, I would like to situate the CBC Health Services as far as healthcare is concerned in Cameroon. There is a lot to be done because in Cameroon, we run a parallel drug supply system. The government has its own supply system that starts from the central store and gets to the regional warehouses and then goes down to the health facilities. The CBC Health Board also has its own supply system that runs alongside that of the government, even though we get most of the supplies like vaccines from the government supply chain, the central store, but then it enters our system and moves. But what will interest you is that in Cameroon, government sees about 50%. They provide healthcare to about 50% of the population. Now, the remaining 50%, 40% of that remaining 50%, that is about 80% of the remaining 40% is taken care of by the faith-based institutions. And in Cameroon, the Cameroon Baptist Convention is the same government. We see 1.3 million patients annually, according to our annual report of 2020. If not for the crisis, will be more than that. And then, if we are seeing this number of patients, the second thing is that we go to where the government cannot go. we operate more in the hard to reach areas of the country. And so if we are talking about reasons to supply and to support our supply chain, you see to it that if you take away the Catholic Baptist Convention health services, you are just directly saying that about maybe 30 to 35% of the population of Cameroon will be without healthcare because where we go, the government cannot. And so we need people to be able to send us to that place. So we truly, truly will need support.
Wow, thank you. Thank you.
Thank you very much, Carolyn, Karen, and Naga Edward. Thank you for those insights on a very important area of supply and demand, and of course, supply chains in particular. We'll now go on to our next next session, which is by Alison Flynn. And Alison is a senior program advisor for health and nutrition, World Relief, based in Malawi. Alison is a co-chair of the Health of Women and Children Working Group, and she will talk a little bit about their work. Over to Alison.
Thank you so much. Today, I'm happy to share with you about the Health of Women and Children Working Group. Paul Mosley, who works at Mennonite Central Committee, and I have the pleasure of leading this group, which focuses on an area that many of us at CCIH, many of us work in working with women and children and families. So as a working group, we really focus on how faith-based organizations have a critical role in maternal and child health programming. There's so many topics in this realm, but as part of CCIH, we can look at how can we play a critical role. And so we have two key priority areas that we focus on as a working group right now. And so the first is maternal health. So within that, we're especially looking at maternal mental health and also respectful maternity care. And you may have seen in the last year or two some various webinars to this effect with some really interesting participants. Second of all, we're looking at adolescent reproductive health. So we're working with CCIH on an adolescent sexual and reproductive health guide to share about experiences of our participants, of different members of CCIH. And so if that's an area where you have experienced something that maybe you're working on now, we would love to hear from you to contribute to that. And also would love for you to join us as part of the working group. So whether it's that or anything else I've shared, or this is an area that is of interest to you or where you're working, we would love to have you join us as part of the working group. There's a link in the chat box that will give you more information about who we are as a working group, how you can get involved. And it's a great opportunity to learn and to share and to connect with each other. And so we look forward to participating with you. And yeah, thank you so much. I hope you have a great rest of the day at the conference.
Thank you very much, Alison, for that little insight that you gave us about the work that you do as a working group. Always an important component of any system or any infrastructure as we look at quality and improving them. So just, we've come to the end of our talks, and it is, I do see a few questions. So we'll quickly have a time of question and answer. But before that, I just want to say thank you to each one of our esteemed speakers, the panelists, for giving us your time and for giving us your insights and from your very enriching experiences. And also just to say thank you for keeping time. Really appreciate that. So quickly to the questions. We have one question already answered in the chat box from Richard. Thank you, Douglas and Tembi, for addressing that. May I go on to the next question, and that is for Dr. Sodzi. The question is, what do you recommend when quality is very low in a facility? People may struggle to know where to turn. They blame lack of resources and also may not have key knowledge. Staff may leave. Can quality improvement processes change things? And if so, how can outside actors also help? Dr. Sodzi.
Yes, quality improvement can certainly change things. And that's also because the whole idea around QI is its ability to be deployed in resource-constrained settings. So we can maximize processes, we can work within the resources that are available within the health system, even before we start making big changes like building a new department or creating a new OPD and bringing in new members of staff. All of those inputs are important, but there's always a little that we can do within the constraints that we face. Capacity building is also critical, as in getting people to speak the same language and to understand the needs. And if you go to ihi.org, there are some resources that are available on the Open School. I would also mention the International Society for Quality in Healthcare. They have a number of webinars, free webinars, some courses that can be taken at that level. So you see that you create a sense of a community and you can learn basic methodologies that you can use, and you have access to a number of tools. But to also know that they are structured programs. So if you are in the leadership position, then you would want to carve out a vision for your facility, but then also provide resources to train your health staff so that they feel supported in taking this journey forward.
Thank you, Dr. Sodzi. We have another question for Cassandra, the nursing student. We are excited to talk with the student in training because normally we get people who have too much experience that they forget what they learned in school. What one or two things have you learned in your program at Bishop Stuart University that would help you improve as a professional or improve quality of care? Cassandra. Is Cassandra there? Could you please unmute? Yeah, Cassandra, thank you.
Thank you very much, Madam Priya. And we have learned so many things so far, because it is that when we are providing care, we should not only just provide the physical care. If a person presents with the illness, we shouldn't just provide the medications. However, we should put in more other things like treating emotionally, spiritually. For example, in some wards like cancer wards, we always provide, we always get preachers, bishops to always come and talk to these people, giving them the spiritual support. And then also have, we're also taught to give them the emotional care. And this is done through counseling, and we're taught how to counsel patients. And then economically, some of the patients, since we are in low-income countries, most of the patients are not economically well. So if we find a patient who cannot afford anything, of course, all the patients, it's not that they can't afford. So always request other patients who can easily provide, so they can also help these patients into like surviving. So you find that when you're providing care, we are not only giving the medications, but we are giving a whole package, and this improves our quality of care and improves the patient's well-being. Thank you.
Thank you, Kasanje, for that answer. Next question is for Dr. David at UPMB. The question is, non-communicable disease is important because it is the fastest growing threat to health outside COVID. What is the single greatest limitation to seeing it expand in church-based health services? Should churches, communities, and health facilities link together more on this? Dr. David?
Yes, thank you so much for the question. Of course, the biggest challenge has been capacity building for the health workers, community health workers, and who are to create demand for early detection of the NCDs. Additionally, it is the documentation and reporting of these health outcomes such that we ably use the data for planning in terms of human resources for health, in terms of availability of quality medicines. Additionally, it is in terms of using patient history. Most of our patients, for instance, did not have any history. So they are seen as new patients at every facility they go to. So that as well is looked into. So it is a holistic kind of thing.
Okay, thank you, Dr. David, for that. Okay, the next question is for me, but before that, let me ask the question to Peter. The panel mentioned SASA faith a few times in your panel. How did you decide that you needed to address violence against women in an HIV program? Where can we find out more about the SASA faith curriculum? Dr. Peter, please.
Good afternoon. The SASA faith curriculum, we can share that, but just to mention that this is material that is used by the Malawi Interfaith AIDS Alliance, which helped us to do the trainings. So I'm not very sure whether that can be found on their website, but it's something that I'm sure in terms of the material, we can share that material. Thank you.
Thank you very much. Yes, so thank you, Dr. Peter. And there's a question for me regarding our experience in India. Well, I come from a country which has 36 smaller countries within it, because each state has its own powers when it comes to health. And we always say that health is a state subject. And with that, we have 36 of them, both states and union territories. From all that is mentioned in today's talks by the respected speakers, I would say many of the challenges in our country are very similar. We do come from a country which struggles from very poor health indicators in some of the states, and that's exactly where the quality needs to improve the most. There is a challenge with resources, but I must say that our structures are in place. We are, because, when the government official, Mr. Dr. Khama talked about the monitoring, supervision, mentorship, and evaluation, our country has given us platforms at every level, right from the block level, which looks at about a 1 lakh or 100,000 population. So from there, we as NGOs, we as FBOs are allowed to be represented there, whether it is on a topic related to maybe like immunization or a disease specific. For every area, they have a task force or a group or a working group or a platform, which can be accessed by us with the permission of the government, and they follow it up, from the block, it goes to the district, from the district to the state, and then it does feed into the policy engagement to finally improve somewhere on the quality. Yes, our government is also pushing in a big way for accreditation systems at both the government as well as in the private institutions. When I say private, I'm talking both about the profit as well as not for profit. We do have accreditation systems for laboratories as well as for our hospital healthcare services itself. Lot of work, lot of working groups, lot of partnerships with NGOs as well, including the FBOs. And we are looking at a positive engagement. We are looking at systems that will slowly churn into place. We always say that government will give us numbers. There are numbers, so many children are not immunized, or so many women are not getting good antenatal care, but the NGOs and the FBOs will give you their names. Now that's the difference. And that is the quality of care that we see in our country when we do it through projects, and especially with partnering with the government. So the challenges and the systems and the processes are very similar to our, what we've heard here in our country too. I hope that answers the question, and if there are any more, we'll be happy to answer them. I think the other question has been answered already. Yes, there's one, there are a few more. We have one for the pharmacist, Edward. Do your commodities come 100% from Cameroon government, or do you also have to procure directly from suppliers? If so, how do you handle cost recovery? Edward, that's a question for you.
Are you getting me?
Yes, we're getting you, but there's a lot of disturbance. Maybe Edward, you could put off your video and answer the question. Would that be okay? Maybe that would be better. Yes, and please unmute. Yes.
Okay, are you getting me now?
Yes, perfect. Thank you.
Okay, talking about drug, we do not get all our supplies from the government. Our supplies to the government, but we get some supplies from the government central store, and almost all our vaccines we get from the government central store. But other products, we buy them internationally. We go out and ask for tender. Then companies that can supply us will supply. There are some of our drugs that we buy directly from the manufacturers. And then there are some of the drugs that we procure locally from the other wholesalers who exist in Cameroon. I hope that answers the question.
You're on mute,
yeah, sorry.
Priya.
Yeah, sorry about that. Yeah, thank you, Edward. Thank you very much. We'll go on to our next question. This is for Leticia. I wonder if she has a specific story of how gender equality and social inclusion focus produced a desired change. This will help us advocate to expand this work in our context. Leticia?
Thank you so much for that question. Yes, I do have a lot of examples, but for this question, I'll just share one. We have tried to incorporate gender equality and social inclusion in our programming, as I shared at World Vision. And what we have done actually is to document what we call gender equality and social inclusion and promising practices. So we have several of them. But I'll just respond to one. We have what we call male engagement approach, where we have actually systematically and strategically reach out to males and engage them in our programs and try to use them as agents of change in challenging this discriminating social and gender norms that tend to discriminate some groups like women and girls. And also to use them as agents to help us also fight and prevent child marriage and sexual and gender-based violence. So we have a specific example from Bangladesh that have worked really well, where we have seen a change, transformational change. Now men are being engaged even in domestic activities like, feeding children or cleaning the house and cooking and all those. And also they have been at the front line fighting child marriage. So I can say that yes, our approaches have worked really well in so many different settings. And one of them, since I had to share a specific story, the story about Bangladesh. And I will share a link to that story that will help us expand more about that approach and how it has worked well. Thank you.
Thank you so much, Leticia. Another question for the Malawi Scope HIV team. The points were clear about what makes the program work, but we need to understand the challenges. How have you learned from things that did not go well? Do we have, I think Peter would be there to answer the question.
Yes, I'm around.
Yes, thank you.
Yes, so the Scope HIV project was is a community project, mostly using community-based volunteers. And some of the key challenges that we faced included the low literacy levels of some of the volunteers that we used, which somehow made it a bit difficult to train them in certain components of the work. Because if you are to achieve quality, you need more trainings, more review meetings and things like that. So that called for, or that calls for people with some level of literacy. So that has been one of the key challenges. The second challenge has been retaining the volunteers themselves, because so we are able at times to get these volunteers trained in certain packages, for example, promoting HIV testing or linking people who are newly tested positive into care. And when these volunteers are fully trained, well equipped, some of them drop out because obviously they are volunteering. They drop out when they get other opportunities elsewhere. So these have been some of the key challenges. But working with the government, our colleagues from the Ministry of Health, from implementing partners, we have been able to do our best to make sure that we retain as many of these volunteers as possible, but also using a kind of a low dose mentoring and coaching process. We are also able to get on board new volunteers and get them up to speed in terms of being able to take up the roles of promoting HIV testing, linking people to care, or bringing back people who have dropped out of treatment. So that has really gone on well over the past year and a half. Thank you.
Thank you very much. So there's another question. Maybe I would direct, this is a general question, so I would request maybe Douglas and Chris to answer this. So there is a lot of discussion about technical aspects of quality. What do we as Christians need to think or do differently? Is quality of care possible without thinking about spiritual and emotional care? Douglas, I'd like to give you the first shot at it.
Thank you, Priya. Great question. It seems to me in discussions over the years about policies and where the Christian community fits in, first is to get a seat at the table There's technical working groups, and sometimes I find in the practical level need to use our connections. Relationships count, and many people in positions of authority, the policymakers who we want to influence, are also people of faith, whether they be of our own faith tradition or another. We can often relate to them on the common values that we hold around issues of HIV, safe motherhood, contraception, and how to do these things well to serve the people that we all are trying to serve. I'd be happy to expand, but I'll leave it at that. I'm sure there's other ways to address it as well.
Yes, thank you, Dr. Douglas. Chris, please, Dr. Chris.
Thanks for the chance to weigh in on this. I guess what comes to mind is something we've struggled with where I used to work in Bangladesh, is what is the definition of quality? And the conversation around the value of each life and what are the holistic components to that value, I think has been just very interesting to highlight sort of some cross-cultural differences, some of which are indeed the technical side, but also just the issue of, as Kasande's work actually highlighted, about the issues of waiting time and transport time, opportunity cost of using facilities, but it's the medical clinicians that have actually had those debates. And I think that is just really interesting. And again, from a faith-based perspective, to be able to bring in the question of how do we value people and what elements of that, whether it's from the side of valuing their time in terms of things like waiting and valuing their lives in a short term, but also in longer term, because that's where our debates centered, was around how much time in a consultation with a patient do you spend teaching the patient, their family members, what's going on, but also praying with them. And, you know, in a sense anyway, looking at the longer term holistic health, but then needing to really have that balanced by the issues of people's economic needs, time needs, and things like that. I think that's what's very interesting, is it quality brings up opportunities for a range of things that I think God's word speaks to.
Thank you, Chris. Thank you very much for that. We have another question which I would like Thembi to please answer, since the whole maternal and child health talk which you gave had so many important points to it. So the question is that our world is changing with climate conflict and economic disruption. Are there specific things in community programs and facilities which need to do to prepare to maintain quality when there are crises or surges in healthcare? So because we just can't give up and wait for things to stabilize. So from an MCH point of view, Thembi, anything you'd like to give as an input?
Thanks so much. And I think that's a great question. Quality of care should not be seen as like a once-off set of interventions. Mm-hmm. It should really be grounded right from the establishment of healthcare and anticipating and preparing for any changes and shifts that might happen. I think we saw it with COVID, when COVID emerged. Maternal health, child health suffered because of just, I think what I would just say, lack of anticipating and preparing for that shift and utilizing the health workforce in a way that continues these other services within that quality, within that safety environment, and meeting the individual client's needs beyond COVID. So one of the things I would say within a conflict environment, particularly quality of care becomes particularly critical. This is where the other human elements of quality of care come in. Empathy becomes very, very critical. Yes, we are in conflict, but we are in it together. Understanding that service providers need support themselves to be able to provide quality of care. They can't provide quality of care as we define it unless they themselves are supported to provide that care. How do you support service providers within a conflict? You really have to meet their needs, not just their needs in terms of supplies, commodities, equipment, but also their needs for psychosocial support, their needs for emotional support, their needs to be able to, their needs for preventing burnout. We saw a lot of that within the COVID environment, preventing a lot of burnout. I think that has to be balanced between the needs of the providers and supporting the providers to do exactly what we say is quality of care and define it, and also meeting the needs of the client. And I'm glad some of the discussion here has come to what is the role of the client and the community to support the quality of care that they get. It's not just like them demanding, but also contributing and allowing that flexibility and understanding that that flexibility will happen. And I think really needing to look at both this provider aspects and also the client aspect to bridge that need. Should there be a shift, whether it's due to conflict or should there be a shift due to an emerging epidemic, or should there be a shift in the entire health system? Thank you.
Thank you very much, Sandy. That was, yes, please do, go ahead.
If I could just jump in for a moment. Another aspect that we haven't talked about too much is the role of religious leaders, pastors, priests, and people from other traditions, imams, in the role of facilitating health quality. We live in a world of a lot of misinformation and misunderstanding, whether it's about HIV/AIDS, reproductive health, or immunizations, and our own religious leaders in our own communities are also needing correct, updated information. And when they receive it, they can often be very active participants with their own communities and at higher levels with policymaking in terms of addressing some of those issues. So as Thembi mentioned, the importance of good information that clients and providers need can be facilitated directly by faith leaders when they have the tools and the understanding at their command. And very often they want to be more active, but need the assistance.
Thank you, Dr. Douglas. Thank you for weighing in there. So we're running out of time. So there is a question related to COVID and whether it has threatened quality, but I think Thembi did bring up some points in her discussion when you're talking about crisis and quality and stabilizing the system despite whatever hits it. So maybe we can answer the question later on. I think we can do that as time permits. But just to close the session, I would really again thank each one of our respected speakers for your time, for your effort, for your work, for your commitment. Thank you very much for giving us a little insight into the rich experience that you have had for so many years in relation to quality and improving on that quality. And also a big thank you to CCIH for giving me this opportunity to moderate this session. It's truly been a privilege. And I always, whenever I interact with Doug and the team, I always feel a little bit better about myself. So there you go, quality improvement on a very individual level. So thank you once again, each one of you. I will hand over back now to Mona.
It's been a pleasure. Thank you, everyone.
Thank you so much, Priya, and thank you to all of our speakers for joining us, and all of you for asking questions. I know we didn't get to all the questions, but I promise that we will let our speakers know, or perhaps they'll be looking at the questions in the chat box and may be able to answer. So just thank you so much. Now, at an in-person conference, after a breakout session or a plenary, we would talk to each other in the hallways. We would have meals together, but because we are virtual, it's a little harder to do that. But I hope you will stay with us for the next 45 minutes for breakout sessions for a time of networking. After I pray, there will be a button that appears at the bottom of the screen that says breakout rooms. And that's where you'll move into one of 6 rooms. So there is a room